Hi, this is Dr. Poole again. This is the second part of the tour of cerebrovascular diseases on hypertensive cerebrovascular diseases. After cerebral infarcts, which we already talked about, the most important effects of hypertension on the brain include lacunar infarcts, slit hemorrhages, and hypertensive encephalopathy, as well as massive hypertensive intracerebral hemorrhage. Another entity that we'll talk about that's related to lacunar infarcts is vascular dementia. Hypertension affects the deep penetrating arteries and arterioles that supply the basal ganglia and hemispheric white matter, as well as the brainstem. These cerebral vessels develop arteriolar sclerosis and may become occluded. The structural changes are similar to those that you've already learned about in systemic vessels of individuals with hypertension. An important clinical and pathologic consequence of CNS arterial lesions is the development of single or multiple small cavitary infarcts known as lacunes. These are lake-like spaces arbitrarily defined as less than 15 millimeters wide, which occur in the lenticular nucleus, thalamus, internal capsule, deep white matter, caudate nucleus, and pons in descending order of frequency. On microscopic examination, they show tissue loss surrounded by gliosis. Depending on their location in the CNS, lacunae can be clinically silent or cause severe neurologic impairment. Affected vessels may also be associated with widening of the perivascular spaces without tissue infarction, which is called état criblé. I only mention that because I wanted to show off my French. The arteriolar sclerosis that results from chronic hypertension leads to small lacunar infarcts or lacunes, two of which are shown here within the internal capsule at the top and the thalamus at the bottom. Although these infarcts are typically smaller than 15 millimeters and many result in no clinical findings, they can sometimes be strategically located where they damage important tracts, especially the descending corticospinal tracts, leading to hemiparesis, or the thalamus, leading to sensory problems. This is a low-power photomicrograph showing a circumscribed area of lacunar infarction. There's nothing novel with these. It's the same microscopic progression and appearance that you see with cerebral infarcts that I talked about in the other presentation. Lipohyalinosis, also known as fibrinoid necrosis, affects small vessels and is associated with lacunar lesions. Based on experimental studies, it's thought that chronic hypertension promotes the accumulation of serum proteins, including fibrin, in the basement membranes of cerebral arterioles. Continued protein deposition results in these microvascular fibrinoid necrosis. Hypertension also gives rise to rupture of the small caliber penetrating vessels and the development of small hemorrhages. In time, these hemorrhages resorb, leaving behind a slit-like cavity surrounded by brownish discoloration. On microscopic examination, slit hemorrhages show focal tissue destruction, pigment-laden macrophages, and gliosis. Acute hypertensive encephalopathy is a clinical pathologic syndrome arising in the setting of malignant hypertension and is characterized by diffuse cerebral dysfunction, including headaches, confusion, vomiting, and seizures, and sometimes leads to coma. At postmortem examination, such individuals may show an edematous brain with or without transtentorial or tonsillar herniation. So the gross appearance is similar to that seen with diffuse hypoxemia, hypoxic encephalopathy. It's just a clinical pathologic association. Individuals who, over the course of many months and years, suffer multiple bilateral gray matter infarcts may develop a distinctive clinical syndrome characterized by dementia, gait abnormalities, and pseudobulbar signs, often with superimposed focal neurologic deficits. The syndrome, generally referred to as vascular or multi-infarct dementia, is caused by multiple vascular disease or multifocal vascular disease of several types, including cerebral atherosclerosis, vessel thrombosis or embolization from carotid vessels or from the heart, and finally cerebral arteriolar sclerosis from chronic hypertension, which is why it's discussed here. When the pattern of injury preferentially involves large areas of the subcortical white matter with myelin and axon loss, the disorder is referred to as Binswanger disease. This distribution of vascular white matter injury must be distinguished clinically and radiologically from other diseases that affect the hemispherical white matter. In addition, many individuals with neurodegenerative diseases resulting in cognitive impairment or dementia also have evidence of cerebrovascular disease. So in vascular dementia, the gross findings are primarily multifocal lacunar infarcts of the periventricular white matter or deep nuclei or both, and cerebral atrophy and ex vacuo hydrocephalus from the reduction of volume of white matter. Microscopically, nothing really new here. There's extensive atherosclerotic or hypertensive microvascular changes or both, which includes hyaline arteriolosclerosis and lipohyalinosis. This is a series of postcards showing vascular dementia. There's multiple vascular events, including embolic arterial occlusion, atherosclerosis with vascular narrowing and thrombosis, and hypertensive arteriolar sclerosis. There's a coronal sections showing multiple lacunar infarcts, loss of white matter, seen in the bottom panel in particular. With extensive loss of white matter, there's bilateral ventricular dilatation, also known as ex vacuo hydrocephalus, as a result of the extensive white matter vascular disease. And you can also see some of the lacunar infarcts involving the white matter here as well. This will overlap with and introduce intracranial hemorrhage, but I'm starting off the discussion here with hypertension since it's such an important cause. Spontaneous intracranial hemorrhage is thought to account for about 10 to 20% of all strokes, and hypertension is the most important underlying cause. More than 50% of spontaneous acute cerebral hemorrhages occur in hypertensive individuals. 70% to 90% of patients with intracranial hemorrhage have high blood pressure. Cerebral hemorrhage accounts for 15% of deaths in patients with chronic hypertension. Spontaneous intracranial hemorrhage reaches a peak incidence around 60 years of age and is 5 to 20% higher in men. This is the table again outlining characteristics of stroke subtypes and just pointing out that intracerebral hemorrhage does not improve during the early period. It progresses gradually over minutes or a few hours. So you should contrast that with the clinical course of ischemic strokes, as well as subarachnoid hemorrhage, which we'll talk about later. Acute hypertensive intracranial hemorrhage typically occurs in the distribution of the lenticulostriate branches of the middle cerebral artery and in the pontine perforators of the basal artery. Accordingly, hypertensive hemorrhage arises in the deep cerebral nuclei, cerebrum, cerebellum, and pons. The clinical picture of hypertensive brain disease varies widely from massive acute intracranial hemorrhage resulting in rapid death to a chronic, slowly progressive dementing illness, which I talked about earlier. Between these two extremes lies a syndrome of hypertensive encephalopathy, which is caused by usually an acute increase in systemic pressure. Acute hypertensive hemorrhage of the pons, one of the less common locations resulting in acute brainstem swelling. acute hypertensive hemorrhage arising in the region of the basal ganglia, a more typical site. There's a striking mass effect with herniation and focal extension into the lateral ventricle. So let's recap. We defined hypertensive cerebrovascular disease, which may result in lacunar infarcts, slit hemorrhages, hypertensive encephalopathy, spontaneous intracranial hemorrhage, and vascular dementia. You learned about the location of lacunar infarcts and contrast that with the location of spontaneous intracerebral hemorrhage. You should be able to recognize and describe the gross and microscopic findings and the blood vessel changes that are seen with hypertensive cerebrovascular disease. I know there's a lot of pathology material in this block, but don't get like Ren here. Keep your blood pressure down, and you'll put this all together eventually. Hang in there.